Hello, everyone,
Hello
and
everyone,
welcome to
welcome
this.
to the
Hello, everyone, and welcome to the show. We are going to start in about 12 minutes from now. I hope you will enjoy this webinar as well. Please feel free to send your comments and your questions. Hello, everyone, and welcome to the program today. I hope you will like this program again. And also, thank you very much for your continued interest in the news webinar series. And I hope that all you already know that all of these webinars are certified. They do have a certificate, but this time we do not have a quiz because it's been a little bit of busy over here. As you know, all know that the AANS meeting is also ongoing right now in Boston, and well, I'm not attending it in person. I do have some interest with my section over there, so I've been a little busy lately. So again, thank you very much for joining. At the end of the session, please send me your email address so that I can email your certificates directly to you. Thank you very, very much again. Please feel free to send your questions and your queries and your comments and your suggestions in the chat box. I'm looking forward to taking up all your questions and your queries at the end of the session with Dr. Kaliaperumal. As you know, Dr. Kaliaperumal is a very well-known neurosurgeon from Edinburgh and with a lot of contributions in this field of education and mentorships. So I hope you will enjoy this webinar. Hello, sir. Hello, sir. Can you hear me now, sir? Hello, Dr. Kalia Perumal.
Hi, can you hear me?
Yes, I can hear you. Thank
Okay,
you very much for joining us today.
no problem. Let me see if I can.
Yes, I can see you too. Your
Perfect.
video is
Oh,
now. Thank you very much for joining us today. I know it has been a very busy day for you, and it's weekend as well. And I think there's a lot going on at the Royal College of Surgery in Edinburgh nowadays because of the diplomate ceremonies and everything.
all right. Okay. No, thank you. No, I'll just wait. So it's 5 o'clock, isn't it?
Exactly. We've got 9 minutes to go, but please feel free to check your presentation and your videos so that you can, that you can see if there's any hitch in that way.
No problem.
So everyone, I'm just going to resume from here. I hope that you are all members of the news WhatsApp group, where I continually update about all our upcoming events and everything. And you also know that we have got an ongoing Park China webinar series with Professor Atul Goyal, and it will be held. The next webinar will be held on pretrocleval meningiomas next month. I will be sharing the details at the end of today's session so that you can actually come across it and feel free to get registered. So as I have told you before, all of these activities do have an attendance certificate. So please send me your email IDs at the end of the session so I can actually send you your attendance certificate. Usually I have a quiz at the end of the session, but this time I wasn't able to complete the quiz. I'm sorry for that. Because as I told you, I'm also looking after some other webinars right now and with the AANS, so I'm sorry I wasn't able to craft the quiz this time, but I do have your attendance certificates ready, which I will be emailing to you at the end of today's session. And Professor Chandru, Dr. Chandru, would you like to check your slides right now? Great, sir. Yes, I remember I had the honor of delivering a lecture for the Newsman series. It was a very good experience for me. You have a wonderful team at Newsman. Medical students were very enthusiastic, very nice. I remember that.
Thank you for that. Looks like
We've
you
got
guys are quite busy with various seminars. So I see that you have your own group of, is it neurosurgical trainees based in particular part, or is it just global, or what exactly?
it's basically global. Actually, I run news. I'm also the co-chair of the AANS CNS Trial Section for Tumors for the ANS. So I look over their education committee as well, the communication committee. But I also run my own group, and it is called News Neurosurgery Enthusiastic Women Society. But actually, it is open for both women and men, and for every level of neurosurgeon, whether they are trainees or they are young neurosurgeons or whatever. But most of the time, the neurosurgeons that I have in my group are mostly the consultant level or the attending level neurosurgeons, but it is open for all. I've also ran a group for medical students at the WFNS when Professor Borba was the chair of the education committee in the WFNS. He's now the president elect for the WFNS, but I haven't yet resumed working with the WFNS for quite some time because I've been quite busy with the AANS. You know, the American Society is a lot of work to do, and because of recent advances in brain tumors, etc. So it's been quite busy there. So
Yeah.
I'm just looking after news right now.
Very good, very good. I think it's good to see that you're keeping yourself busy and trying to motivate people. And I think people get inspired, or they just get in touch with you. And I think it's just finding the right portal to tap into the resource and also
It,
establishing connections. I think that's very, very important. Um, End of the day, whether you are in east or west, the concept is
yes,
same.
yes,
And a lot of people actually, on the contrary, you feel that people may not welcome you, but actually, the moment you are up to it, you will be welcomed by anywhere in the world. I think that's the most important message that should go to all the participants and also to everybody, I think. Yeah, so that's really
exactly.
good.
Exactly. So I believe there should be a bridge between, between the teachers and the students. That's what we are doing, that we are actually closing the gap between the teachers and the neurosurgeon from around the world. So it's something which is I think most fulfilling for me personally, and it caused a lot of satisfaction on my part, because when I was a trainee myself, I thought that we did not have that much of approach, and we did not have the chance to learn directly from someone who is much more experienced. And this holds special importance if you belong to some developing countries, because the level of training is not that much up to the mark, and
Mm.
the chances, because whenever the level of training and competency is not that much higher, the politics is quite, it's quite complicated in those countries
Yeah.
where, and everyone is trying to compete and trying to, damage other. So it gets a little bit of
Yeah.
difficult, complicated. So I believe that this is a huge privilege that we can now actually meet people virtually, and can have this privilege of directly learning from others and directly interacting with others. And I owe a lot to teachers like you and everyone who agrees and accepts to come and share their knowledge. And I believe that it has made a lot of difference, because sometimes I see people share, they give references that we learned this from that webinar, we learned this from that teacher. So I think this is really great, and I really appreciate your efforts too in that means, because you have open Newsment. I believe you will also give a little introduction of Newsment to
Mm.
our attendees.
Yeah, so I'll talk about it. I think the main aim is getting a message across, and making the concept clear. I think it's important that neurosurgery is a developing field, and then there is quite a number of things which we have not tapped into. So understanding the concepts is more important, and when you connect with people, you always learn something new, and you get your trainees on board, and it doesn't matter where you are. It doesn't matter which part of the world you are sitting, and now everything is connected now. There's so much resource out there, and which one to trust, which one not to trust, and which one to actually take it on board and keep it for your practice. And that's something that I'll talk about today. So yeah, so I wonder the participants. I want them to talk to me, not sit quietly. So uh, because I don't want this like unilateral lecture, because I want people
Yeah.
to stop me and say, can you explain this? And
I
I
will
want this more interactive. Yeah.
I will certainly make sure that everyone has got. I usually take questions at the end of the session during the discussion
Yeah.
period, but if you like, I can ask them to send questions during the session so that you can take them up and just
Yeah.
explain
Yeah.
this
That's
to
fine.
them the way
No
you
problem.
like, every way you like. But sir, you are very right because exactly you are exactly right because several of the studies that are being published now, because I also work for the AANS, like I said before. So we all have to go through a lot before sharing a study, because sometimes the results are like not that much. Sometimes you think you have to think whether they are really relevant, they are really fine enough to. And also, I think that people should have an insight that it's not like one size fits all. This is just a suggestion, and you have to tailor your approach to each your patient and according to your given circumstances and according to what you have right now. So I think this is something that we really need to, and I really wish to discuss. So when I
Yeah.
was in New York a couple of months ago, I saw that in on their TV channels they were like showing a lot about sports related head injuries all the time so that they can actually educate the general masses. And I think this was very necessary because there were a few cases when I was even there in New York. I saw that there were a few cases when a child who sustained head injury and he was in a lucid interval, he was actually sent home, and where he actually collapsed, and nobody knew what happened to him. And this was basically a lack of knowledge on that part. When he sustained that injury and there was nobody there to know that what was happening inside, and he was lucid and he was sent home, and it was really serious. So I believe that there is also a need to address the general masses regarding head injuries, because sometimes they do not know much
Yeah.
about the things that they should be knowing, especially in schools and colleges and wherever there are students. So I believe that this is very important.
Absolutely. I think that there's so much. So I'm just looking at the timings as well. So I think we got, should we just wait for another few minutes and then are you able to see
So
my
you
screen?
Yes, we are able to see your screen, sir. I believe we can start now because for sure, because people will keep on joining us in the middle. They usually come hopping in during the webinar. So if
Okay,
you
yeah, that's
just
fine. Yeah,
allow me, I would like to say a few words of your introduction.
yeah, no problem. I
Thank
think we
you
can start now.
very
Yeah,
No, it's okay. You can just keep it on. So it's a matter of great honor and pleasure to welcome Dr. Chandru Kaliaperumal, who is a consultant pediatric and adult neurosurgeon working in the Royal Hospital for Children and Young People and the Department of Clinical Neurosciences based in the Royal Infirmary of Edinburgh. Dr. Chandru has a brilliant career with achievements starting from medical school, where he achieved gold medals, and later he won the prestigious Kamal Said Prize during his neurosurgical residency. And recently, he has been given the Outstanding Role Model Award by the NHS. He has, yeah, as you can see, he's also the founder and chair of the Newsment Initiative, which he will be, which he will, talk about later during this webinar. And I hope that you will find it very helpful. I had the honor of presenting at one of the Newsment webinars, and I found it very much helpful. And the initiative was very brilliant. So thank you very much, Dr. Chandru, for joining us today for this very important talk on cranial trauma in early childhood. An update. I think it is something that we need to discuss more. So thank you very much for coming today, sir. The floor is all yours now.
Thank you. Thanks, Dr. Maria, and thank you so much for everyone who are participating today. So I'm just going to talk about the updates in cranial trauma and pediatrics. This is a vast topic to cover, and I can't do justice by saying that in half an hour or 45 minutes I'll cover everything. So I declare no conflicts of interest. So just move on. I'm just going to touch base on the basics of pediatrics and adult. And if you compare the anatomy and physiology in pediatrics and adult, there's quite a number of variations that we all know about. And this is a very important determinant in children having traumatic brain injury and how they recover from it. So if you look at sort of the incidence of hypotensive episodes are much more in pediatrics compared to adults. And the cardiac output is, of course, very high in children compared to adults. And this has a bearing on children developing edema after a traumatic brain injury. So there is no update. How, as they say, there is no future without past. So I'm just going to briefly go through some very important key aspects of pediatric traumatic brain injury before I go for the update. So I'll be very quick. So we'll start from birth. So this is a famous aphorism by Sophocles, and well before the Christ, 500 years ago. To give birth is a fearsome thing. Of course it is, and we are living in a world where we appreciate the womanhood and we celebrate womanhood, and we also want more neurosurgeons who are women in across the world. And there seems to be a discrepancy, and hopefully through channels like this, through Dr. Maria, I'm hoping that there'll be more participants who are willing to join and become neurosurgeons. So anyway, so I'm just going to talk about this illustrative cases before I move on. So this is a baby who was born by forceps delivery in a private maternity hospital, and this child started developing jaundice 48 hours after delivery. There was a little boggy swelling, and the child needed transfusion. But because of the swelling in the scalp, the baby underwent a CT scan. As you can see, that there is a forceps-induced ping pong skull fracture. Isn't that what we call it here? So a skull fracture, we don't have to do very much about it because most of the times they get better. So this is without any intervention. 4 months later, so the skull bone is quite malleable and resilient in a way. So you can see that child has gotten very well without any neurosurgical intervention. Now I just sort of try to bring in some old papers and then I compare it to the new one. So it's very, very common to have asymptomatic intracranial hemorrhage in term infants, but not a lot of times they don't get picked up. So we just have to be very careful about how do we deal with this and how do we treat these children. So this is a difference in the modality of delivery. You're talking about vaginal delivery, vacuum, and forceps delivery. You can see the amount of subdural hematomas are much more prevalent in vaginal deliveries compared to forceps and vacuum, and also through cesarean section. There is a small percentage as well. So, so I'll just talk about a 10 weeks old baby who presented with sort of right-sided seizures after a fall. You're talking about a 10 weeks old, it's hardly 2 months. It's one of the twins born a term. There was no neonatal problems, but then the initial CT showed some abnormality. As you can see, there's a little bit of subdural hematoma, bifrontal contusions, which is probably evolving. And we did an MRI scan. As you can see, that there's a number of changes in the basal ganglia, more in the hemisphere, and a lot of DWC changes on the MRI as well. And the story slowly unfolds. So we investigate the child and then we do fundoscopy and we see this picture. So this is a very classic picture. And it's very important that we talk about things other than trauma, which is a non-accidental injury. Now, it used to be called by different names. So shaken baby syndrome is that terminology has been completely given up now. So it's going to be a different form of definition for this called abusive head trauma. So it's a significant amount of children who present. We don't even sort of recognize that. But if you see multiple retinal hemorrhages of varying age with subdural collection and multiple rib fractures, obviously you need to be thinking about abusive head trauma. So why am I talking about this? Because it is very important, because the mortality from abusive head trauma is much more than traumatic brain injury from accidents. It's easily missed, and there are a lot of other differential diagnoses we need to think about. So I think it's important to have this sort of awareness about abusive head injury. But if a child has meningitis, then particularly from Neisseria meningitis or hip influenza, hepatitis, Haemophilus influenza, and not hepatitis, Haemophilus influenza, you get sort of subdural effusions, and that can be sort of misinterpreted as abusive head trauma, and including benign macrocrania or macrocephaly of infancy, where the child have big head, and you do a scan and you find subdural hygromas, not subdural hematomas. And some children have congenital coagulopathy, where there is bleeding diathesis, and then you find multiple hemorrhages. So because we know about abusive head trauma, we don't want you to jump in and say that this is abusive head trauma. Another differential is a rare condition called glutaric acidemia type 1, where you can get sort of, subdural collections, and that can be sort of misinterpreted as well. So, yeah, so direct and indirect ophthalmoscopy, it's very, very important to understand the child, even though the child comes with sort of head injury, from investigating the child from a head injury perspective. So, yeah, sort of, I'm just sort of trying to touch base on this because it's absolutely vital for treating doctors and clinicians, even pediatricians, to know when to refer the child to neurosurgery and what are the medical legal implications and how it affects the child as they grow older. It's absolutely important, and it's emotionally very draining, because if you don't have the diagnosis right, you're putting the family through a significant amount of emotional roller coaster, because they may not have done anything, but we always have this in the child's best interest. Yeah. So please do not try to jump into conclusions until you have all the evidence that's available for you to make sure that this is not proper traumatic head injury. Okay. So I think this is a very nice paper. I think it's published earlier this year, where they summarized abusive head injury, sorry, abusive head trauma is a leading cause of death in pediatric trauma, particularly in infants. The mortality is quite high. 1 in 4 children do die. And there is so many factors that gets involved in managing these children. Okay, so just quick recap of a few other things. Skull fractures, we saw about it. Ping pong fracture doesn't need anything done. And in terms of trauma, so we have this 16 months old baby who fell off of, I think, about 6 foot height. Child was very unwell, needed intubation, ventilation. You can see that the child has a linear skull fracture. But then the child sort of got readmitted after 4 months after the initial conservative management. Came in with a fixed dilated pupil with a GCS of 3. And this was the hematoma that you see from the linear skull fracture. I think this is a very important point that we need to understand. So I think for each and every one who's here, if you see skull fracture in a child less than 12 months of age, remember that you need to just do a follow-up, sort of a clinical follow-up at least, to make sure that there is no growing skull fracture. Okay. So this is a fascinating case of a growing skull fracture, where the concept, as you know, growing skull fracture, the fracture grows with the child, because when you get a cracked skull, so the leptomeninges get caught between the fractured segment, and as the child head grows, the fracture grows as well. So It was very interesting when the parents said, "Oh, we got soft spot in the front. We found that the baby had a soft spot on the side." So it took about 5 hours to fix that. So very, very difficult ones, growing skull fractures. But remember, 1% of children less than 1 year old will have a growing skull fracture, and this is just a rough estimate. Yeah, so they're quite complex to repair. And then comes a standard road traffic accident. In a 4-year-old boy, can see a chip of bone in the front, needing a bifrontal craniotomy and correction. And majority of the times, they do well. And before I think you all joined, Dr. Maria was talking about how you get lucid interval from children presenting with a big sort of extradural hematoma, probably sometimes sent home and come back within 24 hours, rapidly deteriorating with a very bad GCS. So they all do well, you know. So I think this sort of an introduction just to give an idea that um, common things are common and advances come, and then there is no limit to how much advancement we can make as a team across the world, and irrespective of where you are based in the world. But there is a massive, um, what should I say? When we talk about low middle income countries and the higher income countries, there is a lot of political um, and aspects of health economics, which is very difficult to sort of, you can't put a blanket statement and say, this is our conclusion, this will be applicable for everywhere in the world. And it's very important to understand the epidemiology of head injuries in children as well. So I'm just going to touch base on that now. I'll be reasonably quick. If you have any questions, please do feel free to discuss in the chat room, and then I'll explain and answer things. So we'll talk about briefly about some trials, quite a number of clinical trials that's going on. I don't want you to get overwhelmed with all the acronyms and names that are get sort of involved with the trials. We'll talk about management, particularly important aspects that we often have to understand, and what type of role does artificial intelligence have in pediatric traumatic brain injury, and these are very, very important. So going back again, so you're talking about a global burden, 27 to 60 million new cases of head injuries. That's sort of presence that we know of. But remember, when we're talking about low and middle income countries where there is not much resource to even document, head injuries, and so we don't have a well-organized data collection for these children in different parts of the world. So we really don't know what the actual burden is, but we assume that this is probably around that sort of the volume. And interestingly, there are different centers where they consider children up to age of 21. And there are some centers which consider children, they're up to 13, 14, and they don't consider children who are 15 as pediatric age group. So it's quite a number of variation. And of course, when you talk about research, it burns down to funding and how much voluntarily people are sort of contributing to it, and then how much initiative and enthusiasm they have, particularly in terms of mentoring and having sort of an established sort of group of researchers who can help you with younger people like you guys who sort of participating globally. So yeah, so even in terms of we spoke about age and children, we know that children's brain are quite resilient, and the amount of neuroplasticity that happens in children are much more significant that we see in adults, but they are very less tolerant to any type of insult to the head. So it's just not about recovering from head injury, but it's about the long-term outcomes and how much of um, other associated difficulties they go through, particularly psychiatric problems. And they started having, they develop criminalities and criminal behavior. And there is a lot of difference in sort of ethnic and racial motivated racial factors that also have an impact on the outcome in traumatic brain injury. It's important to understand that there is no internationally constituted adapted guidelines for pediatric traumatic brain injury. It's the most widely cited, as you know, is Brain Trauma Foundation supported guidelines for pediatric severe traumatic brain injury. And I just want to emphasize we were focused on severe traumatic brain injuries. I think there is more and more now emphasis on mild and moderate traumatic brain injury because we see there is the milder form of head injuries do happen very often and more frequently. And there is sort of a lot of ambiguity in how we manage these children in terms of long-term outcomes, even though the protocols are being set in each and every hospital. Okay. Um, so coming to the level of recommendations. So I'm sure we all know that um, the recommendations in terms of if you talk about class one, two, three, four levels of recommendation, it's very important to understand that there is no class one evidence for management of severe traumatic brain injury in children. So there are only three level two recommendations. We'll talk about that. The rest of them are level three, which in old terminology, it's sort of what we use as options for these children. So if you talk about level two management, level two recommendations, the two are negative recommendations, which is very important too. And one is a positive one, which is a bolus hypertonic saline. It's recommended for children with intracranial hypertension. And we don't recommend hypothermia or even immune modulating diet, which they thought could be beneficial in these children when they go through traumatic brain injury. So, important fact for everyone to understand is the pediatric GCS, the Glasgow Coma Score, is different to adults, and not many times you understand how do you actually look for, when the baby coos and smiles appropriately, and then when is it when the baby grunts or screams and cries? How do you quantify the Glasgow Coma Score, in pediatric issues? Very, very important. And if you don't do it regularly for pediatric trauma, you would be finding it very difficult to use the coma score in children. Okay. Now, just touching base upon Mayo's classification of head injury, and a lot of medical legal um, firms, they look for head injury not just as mild, moderate, and severe. They want a classification of head injury based on Mayo classification, where they look at multiple other factors. Interestingly, they divide it into symptomatic, possible mild TBI, and mild and moderate to severe. And I don't want to go into details about it, but it's very important to understand that the classification is very, very important. Universally, for me to understand what happens on one side of the world, if you refer a patient to me saying, this is Mayo, moderate to severe, then I will know what exactly you're talking about. Um, Anyways, now so moving from TBIs, so the diagnosis. So the most common thing across the world, yeah, we get CT scans. There was a group of American research group that looked at a rapid sequence MRI scan without sedation. So where the children don't get sedated, but they get an MRI scan. But it's interesting that even the MRI scan sometimes fail to detect sort of pathologies like skull fractures, which you don't see very impressively compared to a CT. So, just introducing to you to Enigma Group, which is enhancing neuroimaging genetics through meta-analysis. That's particularly, a group that's looking at advanced MRI biomarkers for prognostication purpose, and which is very, very interesting topic to consider. So then we have a pediatric emergency care applied research network called PCAN. Okay, quite a number of acronyms. They clearly specified the child who will need to have a CT scan when they present to accident or emergency. So I'm not going to go through everything, but just important to understand that, history of loss of consciousness more than 5 seconds, and if you have a very good history of mechanism of injury, then if the parents say that my child is not okay, and you should have a very low threshold to do a scan to see what's going on, because you'll be surprised if what could be the underlying reason. I'm not talking about just trauma, but multiple reasons, and children can present with varying sort of presentations. It's quite difficult sometimes to pinpoint. Yeah. Okay, so I think if you look at the evidence currently, CT scan sort of remains the most used and utilized investigation for TBIs in children. And there are groups of hospitals across the world. They want to do MRI scan. They do MRI scan for children and on a regular basis to look at what happens, particularly severe traumatic brain injury, to see how the pathology, intracerebral pathology, sort of evolves over a period of time. Of course, CT angiogram can be done, and it can be done as a part of the CT investigation, and whole body X-rays, just to make sure that we are not missing out on abusive head trauma, because obviously there'll be multiple other injuries. Please remember fundoscopy or ophthalmoscopy, just to make sure that you're not missing that um, part of it. And I'm sure you're aware of optical coherence tomography, which is increasingly utilized again over the past probably about 5 years or more. And there's a lot of pros and cons to every new thing that comes into a management protocol, but we have had quite early evidence to suggest that we can pick things up quite early with OCT, which is optical coherence tomography. So now specifically going into a few things which we all know about. What's the evidence for ICP monitoring that's going to be helpful? Yeah, absolutely. There is evidence that only serial, sort of, if you do an ICP measurement in a child with severe traumatic brain injury, and there is a benefit in measuring the pressure, and it has a beneficial impact on the mortality and outcome compared to children with no ICP monitoring, and that there is evidence for it. Okay. And people say, should we just do serial CT scans when children get admitted to ICU with severe traumatic brain injury? Again, there is evidence that only serial CT scans requested to evaluate increased ICP or neurological deterioration resulted in surgical intervention. Otherwise, routine follow-up CT scans did not result in operative intervention for these children. So we know cerebral autoregulation plays a very important role. Of course, if it is impaired, and that's going to have an impact and on child's outcome. And then we spoke about ICP monitoring, and there are centers who do brain oxygen monitoring, looking at sort of the hypoxic episodes and then correlating that with the neurological outcome. Of course, there is non-invasive interventions and monitoring, particularly optic nerve sheath ultrasound. I'm trying to introduce these things again. Probably there may be centers who are probably doing those, but transcranial Doppler again can be used. But all these have to be used in a bigger context. Not a single utility tool. Sort of making an outcome um, based on one single parameter is not going to be beneficial. Yeah. So yeah, ICP definitely. And what's the ICP threshold? We talk about the numbers 15, 20. But again, it's absolutely important. And remember, all these numbers and parameters are all based on adult traumatic brain injury, randomized control trial, which we'll talk about in a minute. But just sort of, there is always going to be an equipoise between, should we do this or should we do that? Should we not do that? Then there'll be a senior neurosurgeon in the department who will say, in her or his experience, this is what we should do. And sometimes we just follow the lead again, with expertise, which of course is very, very valuable. So I think this is the original paper, from Professor Kirkpatrick and Professor Hutchinson. So this is for management of adult traumatic brain injury and ICP management, and when we do decompressive craniectomy. I'm just going to talk about it. I'm not going to go through these details, but just to say that, yes, all the evidence that we have has to be based on the adult guidelines, and we have to interpret and sort of use those criteria to carefully use it for pediatrics. Yeah. In general, so we try to keep the ICP less than 20. And what's the rationale? What's the evidence? Of course, it's going to be very difficult. Sometimes we relax it to 25, and sometimes the intensivist get worried if the ICP goes, more than 15, and they call you to say, should we just give some medical management? Of course. So just introducing you to pressure reactivity index, I think it's important that um, the pressure reactivity, index is an indication of ICP sort of according to the changes in the mean arterial pressure. So for children, again, this is a conditional recommendation. I'm not trying to say this is a recommendation for children less than 0 to less than 12. We try to keep the cerebral perfusion more than 60 millimeters of mercury, and children 0 to 12 probably above 50, but not directly above 60. And again, these are arguable, but these numbers have to be very, very carefully used in the context of overall, management. So, coming to ECG, yeah. So we talk about anticonvulsants and should we just use prophylactic anticonvulsants, but the current evidence against using, if I think it's as simple as if the child has traumatic brain injury and there is a significant intraparenchymal abnormality, there's a 10% chance that the child will develop epilepsy in the future. I'm talking about long term. And if we say prophylactic anticonvulsants, we often use levetiracetam for these children within the first 7 days, to prevent early post-traumatic seizure. And there is a strong recommendation to it. But again, it's not a class one evidence and it's very difficult. And people thought like, why don't we just do ECG monitoring for these children regularly during their hospital admission? But remember, the surface ECG electrode doesn't pick up seizure activity in children, particularly when they are sedated, and it's very difficult. And there was a group of neurosurgical team as well. Why not just have some sort of invasive monitoring? And it sounds very. I mean, yes, we can argue invasive monitoring with ECG for severe traumatic brain injury. But again, by doing invasive monitoring, you're going to introduce more risk of infection, risk of bleeding, and all these things that comes as a package. So what's the evidence for CSF drainage when we have difficulty in maintaining or the maintaining the CS ICP? There was consideration of lumbar drains, external ventricular drain, but again, there is no convincing evidence that CSF drainage is going to be very beneficial for children with severe traumatic brain injury. So there is evidence for administration of hyperosmolar therapy. We spoke about hypertonic saline, and of course, it helps. And there is no randomized controlled trial to say decompressive craniectomy is indicated in children. However, there are quite a number of institutes across the world who consider decompression in children because obviously you can take the bone flap, put it in the belly, and put it back when the child's ICP gets better. Um, and what about getting a tracheostomy early when they stay in ICU? We don't have definite evidence for that, but early tracheostomy reduces the intensive care stay, but then what happens to risk of laryngeal stenosis when they sort of grow older? So that's a balance we need to consider. Okay. So should we just start total parenteral nutrition for children with TBI? Again, there is sort of very equivocal evidence based to say that if you start nutrition supplement for children within 72 hours, they probably with increased catabolism in the brain and body, because it's a severe stressful state for the body to react, isn't it? So by supplementing nutrition is going to be beneficial, and we just have to be very careful with that. So what about blood transfusion if the hemoglobin is less than 7? I think the recommendation again, it's good to have a hemoglobin more than 9 for children with severe TBI, so that the oxygenation will be better. And theoretically, it does help in children in recovery as well. So the current suggestion to perform decompressive craniectomy in children is it has to be done after the first line and second line clinical treatment fails within the first 24 hours of head injury. And there is evidence to suggest that. So if you look at the adult criteria, that the classic trials, the DECRA from 2011, and they do suggest that it helps in reducing the intracranial pressure, but they were associated with worse Glasgow outcome scale and greater risk of unfavorable outcomes. So there was a lot of criticism based on this big sort of randomized control trial. Of course, every trial is going to have some sort of pros and cons and limitations, so we just have to be careful about that. The next big trial in 2016 was Rescue ICP from the UK, from Professor Hutchinson's team. It's a multicentric trial again, where if we manage the ICPs and sort of decompressive craniectomy, of course, this trial showed that there is a reduced mortality, but there's a higher proportion of patients who went into a severe disabled state, so or what we call the vegetative state. So the families usually say, this is my child, or this is my spouse. He or she or my child wouldn't want to be in that state. So why put somebody through a major surgical intervention when you have a lot of things going on in terms of severe traumatic brain injury? That's something just to consider. So this is by Figaji et al. From Cape Town. It's an interesting study, and I'm going to cite this paper later as well, because Figachi has sort of written a very nice update on pediatric traumatic brain injury, which sort of looks at various aspects of it to talk about various evidence that I've been talking today. So this is a paper from 2003. So if you look at, these are the children who have had, sort of the outcomes, an early decompressive craniectomy. So majority of them, sort of survived, if you see here. And these are different age groups. And this was initially, you're talking about good 22 2 decades ago. But sort of it gave an idea that, across the world, that, decompression can be safely performed. Decompressive craniectomy can be safely performed in children with severe TBI. So what do we need? I did say that I'll talk about a few trials. The proper big sort of prospective American-based trial was ADAPT, and then we have another a trial from San Francisco. One is called the TRACK TBI, and then the Center TBI. Center TBI is sort of based in Europe, and sort of these are big trials, and these are a group of eminent, scientists working to address a lot of issues with TBI. But the problem is there is variability in mechanism and care protocols across the world. And remember, most of these cases are seen in low and middle income countries. And again, that's a biased statement, because we talk about trauma as road traffic accident, but then if you come up to the West, and the increasing number of suicides in children is increasing in the US, and also the missile sort of firearm based injuries is also going up. So we can't just say trauma is purely road traffic accident, and that's not the truth. A lot of times for children, for global pediatric research, the numbers are really small, and so we can't get any meaningful conclusions. Yeah. So just a brief touch upon blood markers for TBI. I think S100B is something that's very well investigated in the past. Um, so this is something which had been extensively used and investigated to compare, so the various sort of studies to look at, to see can we predict, the severity of pediatric traumatic brain injury just based on the biomarkers. So there's some sort of evidence to say S100B is useful, and there's also neuron-specific enolase called NSE, and they show promise as a diagnostic tool. But again, there is no 100% five, I would say, definite evidence to say if you have these two markers, then we exactly know how to predict these children in the long term. But just for you to understand that, yes, these stages have been evolving, and we often talk about children, when they get collected from the roadside or by the emergency team. Um, what about tranexamic acid? We use tranexamic acid for pediatric neurosurgical procedures, to prevent blood loss. And again, what they know is if we administer tranexamic acid, and they are not associated with either death or poor neurological outcome, which means we can safely use it. But again, we need to have a prospective clinical trial. So this is a very big topic, role of artificial intelligence in head injury, or what we call the machine-based learning for pediatric traumatic brain injury. I could just sort of, I'll go back onto this slide before I come back to this one. This is a latest paper from the Chinese group here, talking about AI to detect skull bone fracture with an approach called segmentation. Just to cut the story short, if it's like if you feed good data into the computer, and if you analyze any type of skull imaging that gets done in your hospital, then based on the information that gets fed, you can say whether there is fracture or not. But then you look at the false positive cases you're talking about, sometimes you get this sort of emissary vein that can be seen, or sometimes sutures can be misinterpreted as fracture when there is no actual fracture. So there is going to be a sort of you can't avoid artificial intelligence coming into medicine. Okay, of course, there's so much of hue and cry about it. There's so much debate about it, and there is ethical issues. There's so many issues with it. But I think it's a question of smartly utilizing how much we need to take from what we need. And this is the paper that concluded that they did a systematic review, and this is a group, and this was published in Neurosurgical Review last year, where, so if you look here, the conventional novel machine learning models were utilized to predict the presence of intracranial trauma or prognosis in children with pediatric traumatic brain injury. But they have not been externally validated, and they recommended that further research is needed. So it's a question of, should we take this forward? How can we safely analyze the results so that it'll be useful for the future? And that's something that we can talk about and discuss the whole day. So what do we need for the future? So I think we need to expand global networks, particularly groups like these networks where you're able to talk to me, and we start doing some sort of baseline meta-analysis, which is very easy to do from wherever you're sitting in the world. It doesn't need to be based on a hospital, so you can do it. It doesn't matter where you are, you can still do it, get all the evidence, and try to sort of adapt guidelines locally to fit your hospital system, because you can't say we have all the technology, now we need to do all these tests. We can't. There are economical constraints where you can't use all the latest technology. And we wrote a letter to the editor when the recent brain tumor classification came out, talking about molecular subtyping. And we said that it's great to know that there is so many things are happening, and what's happening to some parts of the world where they can't even do baseline imaging. There is no basic facilities to treat these children. And we're talking about state-of-the-art technology and groundbreaking biomarkers here. So I think there is a massive sort of a discrepancy between developed countries or low middle income countries. So we need more and more research. I think that's the only way forward. So I sort of touching base upon this. I'm not sure if you've heard about the word salutogenesis. Now, salutogenesis is holistic therapy for children. You probably are, most of you are surgeons here. We are very good at doing an operation. We are very good at, sort of saying that we have done this great job. But then as the child gets out of the hospital from acute setup, we don't talk about other therapies that go with it to give them a holistic treatment, including diet. We talk about art and meditation. So I'm doing quite a lot of work on this to see how I can sort of bring in various therapies to children who undergo neurosurgery. And this can be applicable to traumatic brain injury, particularly music therapy for children in recovery. So this is a very important topic. I think everyone needs to know this. Individual music therapy has been doing great things to children, particularly when they go through an intensive care setting. Okay, so I'm just going to conclude this. I don't want to talk about too much. I think just to give you an idea of what has happened in the past 3 decades, and sort of what we know for sure now is multimodal therapy is very useful. But you remember the basic principles of treating head injury, whether it's a child or an adult, that's going to be applicable. We need to be absolutely clear about that. So there is, of course, there's going to be a lack of evidence in and what type of recommendations that we can use to support certain things. We have to be very careful about it. You can't quote one paper and say this paper has got everything and that's going to be the best thing forward. No, that's not going to be the case. We just have to use judgment, clinical judgment, your skill, your economic resource, and what can be feasible safely. Use your clinical judgment. So we need more and more randomized clinical trials. Easy to say, very difficult in pediatrics, particularly getting ethical approval. So meta-analysis is very easy in that context. When I say easy, it's easy. We need to bridge the gap. And I think Dr. Maria was talking about bridging gaps. I think it's very important that we should reach out to people and say, well, I have an idea. Should we do something different? And is it possible? And collaborate. I think that's the only way to take forward. I'm just going to ask you all, please read these 2 papers. Okay. Very, very good. They are absolutely recent. And it gives you an idea what to read about, what to know, what you need to know about pediatric TBI. So I'm just going to talk about, I think that's what I wanted to talk about. So Dr. Maria gave a very kind introduction to me, but I'm sort of trying to bridge that gap by talking about this charity that I run in Scotland. It's called Newsment. Newsment is a neurosurgical mentorship for global medical students and doctors. So the aim why I started this was when I was a medical student, I used to write to quite a number of people because I want to be a neurosurgeon. And I hardly had any sort of input from people from the western part of the world when I was sitting in the south of India. And I didn't want that to continue. And I thought, like, what if I just make an initiative and then and try to change that where people can reach out to me. So there are students coming across the world, just to be, for a month or a few weeks with me in the department, just observing, learning things. And of course, I'm not saying where I work is a very big center. We got fantastic team here and quite, oops, sorry, I don't know what I did there. But just feel free to screen that. So there's quite a number of things that's happening in the neurosurgery mentorship scheme, and I want you to just feel free to just go through the website and make use of the resources that we have. Yeah, so get in touch with me. We have a very small group of mentoring team, but there is a number of medical students who participated across the world and who are part of it, and we are doing quite a number of things as well in terms of research and publications. Okay, so I'm just going to stop there. I'm going to ask people to ask me questions. I'm happy for you to come. Don't worry about it. Just show your face if you feel comfortable. Otherwise, just ask me questions. Um, Thank you so much for your attention. I know it's human attention span is 40 minutes. I can't talk more than that. Otherwise, it'll be evaporate. All right.
Thank
Thank
you
you.
very much. Yes, sir. Thank you so much, sir. This was a very insightful talk, and I think it was really interesting. You touched up almost everything that was important. I believe there are certain questions, and I do believe that if anyone wants to turn the camera on, please raise your hands, and I will be happy to allow you to turn your camera on. Sir, thank you very much for your wonderful talk, and like you have touched the artificial intelligence topic, which is very raging nowadays. I believe that a doctor cannot, AI cannot replace, the decision making ability of a doctor, especially a neurosurgeon. So, like I was in ISBN a couple of years ago, and I met Dr. Grace Solanki, and I've been working. I was doing a specialization on application of AI in healthcare, and it was my assignment to create, a model where it can actually read the CT scan. The AI could help read the CT scan and the MRI and can detect brain tumors on its own. But sir, it was like Dr. Grayson, like he very nicely said that he was very much concerned about the black box of the AI. Sometimes AI cannot read the right thing. It cannot differentiate what the lesion is, and sometimes there are things which are normal variations and etc. So of course AI can be a great adjunct. It can help you, but it cannot completely replace your opinion making. So you are very, very right in that. So sir, I also wished you to kindly enlighten us. What do you think about hinge craniotomies and basal cystinotomies in case of TBI in pediatric age group? What do you think about these two things?
So hinge craniotomy, I think I remember in the past 15 years, I've done about probably three or four instead of taking the bone flap out because all you want is that. So I hope hinge craniotomy is familiar to all the colleagues who are here. So essentially, instead of taking the bone out, you're just going to put some mini plates on the surface and let the bone expand and it won't sink inside. Yeah, so that's hinge craniotomy. So it's very useful, but again, you just have to look at the overall clinical picture. And I feel that there is a role for hinge craniotomy. And of course, I can't say that can be applicable to each and every child with severe TBI, but I think that's something very, very useful adjunct in your surgical armamentarium. Now, you asked about basal cystonotomy, yeah?
Cystostomies, yeah,
Um,
exactly.
so
Cystostomy.
I don't have much evidence to say if it is going to be very helpful, but there is no limit to what you can achieve to get some CSF. So the aim is to divert the CSF, I believe, yeah.
Yeah,
So
basically they just do the cystostomy. This was just an idea basically that was being floated initially by Professor I.P. Cherian. So it was something that there were a couple of case reports in pediatric age group where they said that yeah, basic cystostomies can help in pediatric age group as well. But it was just a question that was in my mind, and that I really wish to bring in yeah.
yeah, so if I ask you, how would you say that you can apply that technique to a 2-year-old compared to a 9-year-old to a 14-year-old? I think it's very important that we have to keep these ideas that's out there and try to carefully apply this to your clinical practice because you can't say, well, there's a case report, I'm going to do this for every child who comes into my unit. So we can't say that. But I think there's quite a number of things that, that there's going to be case reports coming in that's level 4 evidence, and which is very important as well. We're not dismissing those things. If there is no level 4 evidence, there is no level 1, as simple as that. So everything has to start from somewhere. So I'm just looking at the questions that's been here, has been posted, and someone has asked,
How long would you go with an anticonvulsant in a child with TBI, with controlled convulsions, for example, temporal traumatic lesions?
oh, so sorry, I'm just going from the bottom. Is it very, how
Yeah,
long should
exactly. It's okay.
yeah. So I think that the simple rule is if there is a lot of contusions, I think there is evidence to say if you give anticonvulsant for a week should be sufficient. Then the question is if the child has convulsions during your treatment, uh, you know, say example, yeah, severe temporal traumatic lesion. if the child sort of, if you give it, say, for example, for argument's sake, the child take about 3 to 6 months to recover. Um, you can safely give it for the time frame, but again, getting the neurological colleagues involved again, sometimes will be very helpful, and sometimes you find it very difficult to say, well, this child needs to be on lifelong, anti-epileptics, because you talk about evidence to say, a small proportion will have long-term epilepsy. So if you ask me how long we should go with child with CVI, so if the child present with convulsions, but no convulsions clinically noticed during treatment, I usually try to give a short course of anticonvulsant Keppra, levetiracetam. I think that was one of the other questions that's been asked.
Yes.
And how long will you give it? I would say, 7 to 14 days is quite sort of sufficient. But if the child has continued convulsions and epileptic seizure, then probably we have to continue it for a longer duration. So I'm not going to say just give it for 6 months and stop, and you're not going to go quote saying, well, this is the talk that you heard, and then you give it for 6 months. But my rationale for giving any medication, I try not to give medication when they don't need a medication. I try to stop them, but it's a clinical judgment, and you need to be responsible for making that decision. Okay. What should be the ICP cutoff for children with open fontanelle? The question I ask is, why would you want to stick an ICP probe when you got the fontanelle that's going to be very, very tense? Okay, so of course the fontanelle is bulging out, that you know that the ICP is quite high. Then you stick in an ICP probe and then wait for a few days and wait for the fontanelle to just sort of relax a bit. So we spoke about the numbers here. So if you ask what is the ICP, I think it's reasonable that we keep the ICP less than 20. Um, and again, it's a very difficult question for me to answer, because what is a normal ICP for a 2-year-old, 1-year-old? Do we know for sure, particularly when you get, sort of an intubated and ventilated child? Obviously, all those parameters will increase ICP by itself. It is a balance. It is a balance and a judgment, I would say, more than anything. Okay, so how long tranexamic? Yes, a single dose of tranexamic acid is absolutely fine. We often get one single shot of tranexamic acid before the child gets transferred from the accident scene to the hospital, and we don't give it regularly. You don't need to. I'm sure there are some places they feel that they can give tranexamic acid on a regular basis. Do you recommend prophylactic anti-epileptic when there is no convulsion? No, that's what I was trying to get to. If the child has no seizure, even if they have contusion, even if they have temporal lobe contusion, if the child doesn't have seizure, you don't need to. So again, when we go with protocols, and that's a judgment you need to make, because that's it.
Exactly. So
So
the early and the delayed seizure, I think this is very relevant here also. Whether the patient had an early seizure or a delayed seizure, that's quite relevant, because a late seizure is more likely to develop into someday into epilepsy as compared to an early seizure, and also whether there was an irritant lesion, because if there is anything that is, there is a lesion that is epileptogenic, that's a different thing. But after that point, if there's something, maybe there is a second, like what we call in oncology, there's a second hit phenomenon. Sometimes people do have to carry some sort of tendency to develop epilepsy somewhere in their life, and sometimes when they get had trauma, that tendency tends to, to express itself, and they tend to have more chances to develop epilepsy later in life, the PTE. So I think this is, like you have very nicely mentioned, it's a very complicated topic to talk about, because ILE has a lot of research on it, and they were trying to develop a blood test to think that they someday to have some sort of a biomarker for a patient with a TBI, to see if whether they would or they would not develop any, any delayed seizures, I believe.
yeah, no, that's absolutely right. I'm sure. I think Dr. Pirzad,
Yes, he's here.
I'm not.
He
Thank you for
actually
joining, and lovely to
actually
see
wishes to
you.
talk to you. Yes.
Sorry, who? Yeah, of course. Yeah, please
Dr.
do.
Ahmed Fawad Pirzawad is basically the chair of the Afghanistan
Uh,
Neurosurgical
uh,
Society. Yes.
Salam alaikum.
Hi, assalamu alaikum.
Alaikum.
Salam alaikum. Salam
Uh,
alaikum, Dr. Maria. Thank you very much.
thank
Excellent
you, sir.
lecture, and thank you. We learned a lot of, and I would like to be in contact with you. And exactly, we follow the Dr. Maria. Uh,
Thank you.
all programs, and it's very useful for us for Afghanistan Neurosurgical Society. You know, we are in a limited condition and
Yes.
limited resources, and it's very useful for us. Thank you very much.
You're welcome,
Thank you
sir.
so
Thank you
much.
so much. Thank you. I think that's the point about this talk is not to talk about latest technology when we are struggling to do basic stuff for our people, right? So I
Exactly.
can't talk about functional MRI here when we can't do a CT scan or an ultrasound. So it's very important. I'm just trying to thank you for that. Thank you for your kind comments. Please feel free to get in touch with me, and of course, drop me an email, and we can be in touch, and I can come back and talk about convulsions. But I think there's a lot of questions about in temporal contusion with no clinical
Exactly.
conversion. Do you give it or not? I would not give it, Joseph Sambataya. So we are not going based on protocol, okay? Because remember the anticonvulsant, what we used to do, phenytoin before, now it's getting changed to levetiracetam. And Keppra is very toxic as well because people do develop Keppra rage. Do you understand what Keppra rage is? People go crazy. People have sold their property. People have gambled away things. And that's a very bad side effect of Keppra. We don't talk about side effects very much because if someone has a seizure, you give medicine. Yeah. Every medicine has got side effect. So, as I said, I keep things very simple. If someone has a seizure, give treatment. If someone doesn't have a seizure, please don't. And remember, whatever I spoke to you in the slides is a recommendation. Yeah, I'm not saying you have to do this. So the level of evidence is very difficult to get in children, particularly seizure and epilepsy, long-term epilepsy. People often ask, and the lawyers come back to you and say, I'm talking about more in the western part where people get sued because you have an accident and people say, well, I'm going to have a seizure in the next 50 years, so I need this much of compensation because I had an accident. So it's very, very difficult to justify that. But again, medical legal issues are more on this side, where we're talking about resource and treatment on one side. So kindly present as email. So do you want my email? I think probably I'll type it here. I can just be in touch. If you look at the website, you'll get more information about how medical students are published in BMJ, and it's all possible. I'm probably, I'm very happy to come back and talk about, how to, sort of in terms of research and for students. I got a resident coming from who was from Tanzania last year, and someone coming from Kenya this year. And of course, yes. So please do, and this is my email. Drop me an email, and happy to get in touch and happy to help in whatever way I can. Yeah, no problem.
So kind of you, sir. Thank you very, very much, sir. Sir, I also believe that there are certain things that, of great public interest, but they have been a little, I guess, underrated because, whenever I go out, I see that there are certain things like the trampoline and the jumping castles, which are quite common in every part of the world, and everyone is using them like for fun. And I think whenever I see them, I have this fear that they are big cause of they could be a big cause of some catastrophe of head injury. And I think in some parts of the world trampoline has already been banned, and so is true for the jumping castle and everything. So what do you believe about these things? I think this should be implicated in public health as well.
Yeah. So I share your fear because if you say trampoline or gymnastics is a sport which is in Olympics and people are performing
Yes,
it, if you look at the way how they train, it's unbelievable,
yes,
right?
yes, true.
Then you're talking about a child who fell off a sofa. comes quadriplegic. Yeah, because you get high cervical cord contusion, and people who
Yes.
walk trip and fall and they have spinal cord injury. Yeah, every day we drive wearing a helmet. We say wearing a helmet is fine when you drive in countries where there is massive traffic. But then, if you have an accident with a helmet on, your chance of having a significant injury is 100%. Okay, so we say helmet is useful, but when that accident happens to the person with a helmet, that is 100%. So I can't say helmet is fine. Of course, helmet is very important. Trampoline, I don't recommend that even for children, but there are when children are sat with their gadgets in their house, with,
Yes.
with their iPads and with their phones, you want children to go and do some physical activity. So doing something is better than nothing. But then it's up to the parents to decide what is good or bad. But if you ask me, trampoline, I would not recommend it. But then the trampoline company is going to come after me saying the neurosurgeon said they don't
Yes, you are right.
don't allow
This is it.
trampoline for children. Yeah.
Yes,
So
yes, you are.
I think the most important thing is there is good and bad in everything, and it depends on how you want to use it. Computer is good, gadgets are good, but if you overdo it, it's fine. And unsupervised, anything can happen. So I don't, yeah. So I don't have an answer for that, but definitely I won't recommend it. Yeah.
Yeah, exactly. This is it. And so there are if we keep on talking about these things, I think it will take a lot of time to discuss every part of it, because there are things like sports related injuries, the concussions, and how to assess pediatric age group and athletes, and return to play, which is another big topic to talk about, and underlying issues like arachnoid cyst is one of the very common questions people usually ask. If there is an arachnoid cyst, can that person go to return to play and do the contact sports? And I think that's usually quite allowed. Most of the people do allow the patients with arachnitis to go and do sport, but I don't think the same is true for those with capillary malformations. What's your view on this? I think this is just for general interest, and it should be the final question. We've got a very long discussion already.
Maria, we are talking about conferences that are being run on these topics,
Yeah.
where after 5 days they would not have an answer, right?
Yes.
So return to sport after head injury is a massive that we can talk about it for as a separate
Yeah.
lecture.
Yes,
And
totally.
and as I said before in the talk, we were focused more on severe traumatic
Yes.
brain injury, but now the focus is shifting to mild and moderate, because
Yes.
it's most common mild head injury that children want to go back to football, contact sport. When can I fly after head injury? And all those topics keeps, all these questions keep.
Exactly.
Well, I'm happy to come back at a different stage, talk about some, because I
Sure.
can't give, yeah,
Sure,
can't give
sure.
one
We will
answer
be
for
looking
that.
forward to your next lecture, because your lecture has been really well appreciated and well received by all the attendees. And I believe that I have received a lot of feedback from you already. So I think that we are already waiting for your next webinars and next lectures, because I think these topics are those that were a little, underrepresented through my webinars lately. I think we had to cover more trauma. People are more interested in trauma because it is a going, there are a lot of cases people dealing with each day. And I think this is a topic of great interest for people, especially in the pediatric age group, the trauma. I think your lecture was so important and so insightful. And I'm looking forward to uh, inviting you next time, at least 2 or 3 times, so that we can discuss both the trauma, the epilepsy, the trauma, the post, the PTE, and also the sports related injuries. So thank you
No
so
problem.
much.
No problem. So it's my pleasure. And good luck to each and everyone who is here. I know you want to talk or you may want to talk, but it's absolutely fine. But just one thing before I keep, feel free to talk to people. Don't have any fear. It doesn't matter whom you're talking to, whether it's a professor, whether it is a medical student or somebody, because you learn something from each and everybody. And the moment you stop doing that, you will stop learning. And please keep your mind open, okay? And wishing you all the very best. I hope I will see you in a different lecture, okay? Thank you so much.
Thank Thank you so much, sir. It has been a
Thank
matter
you.
of great honor and joy for me to have you here and to welcome you and to organize this amazing lecture. Thank you very much, sir, and thank you so much for sparing your time. I know you had a very busy schedule today and you had a case already,
Okay.
and it is also weekend. So, sir, thank you very much. Wishing you a wonderful weekend and have a wonderful weekend ahead. And thank you so much again.
Thank you. Bye-bye.
Bye bye. Bye bye. Everyone, thank you everyone for attending the webinar today. I hope you all enjoyed it. And this webinar it will be available on my YouTube channel. It is recorded and you can go through it again and again. Thank you very, very much. And for those who wish to have to join my WhatsApp group, I have shared the link. Please feel free to join the WhatsApp group. I usually uh, update it quite frequently. You can find the flyers of my webinars and everything that is relevant here on my WhatsApp group. And I have also shared almost all of the relevant stuff that has been discussed during the lecture. All of those things that he has said, I already have those in my phone. So I share all the links, so you can just access all those papers and you can read them.